But thank you very much for that introduction. But before we jump in, I want to invite all of us to do a very short grounding exercise. This is what I'm into now. This is what I do. I'm a holistic nurse. This is what I do. So often in nursing and really in life, we just go from doing to doing to doing, and we don't really just stop and be in the here and the now. So let's be in the here and the now. So if it feels safe for you, if you're driving, maybe you don't do this as much, but if it feels safe for you, just let your feet hit the floor. Let your shoulders soften. And unclench your jaw. Oh my goodness, unclench your jaw. And we're going to do just 3 simple breaths in and out. We're going to inhale through our nose, hold it for a second, and then exhale through our mouth. So let's inhale. Big breath in, hold, and then exhale. Let's inhale clarity. And let's exhale what's no longer serving us. Let's inhale calm. And let's exhale worry. Just one more. Now just let your breath return to normal. Notice what changed in you, even if it changed a little bit. Maybe nothing dramatic, but maybe you're just a little more present in this room now. A little more you, a little more in here. And from now, let's begin. So, still on this one, but my name is Cherish. I am a SANE nurse here at Texas Health. I'm a PRN SANE nurse. Hi, come on in. I'm a SANE nurse here. I'm also a holistic nurse coach, and I'm also the founder of the Trauma Informed Collective. I am a former floor nurse. I was a nurse here on C3 for back in when I was a baby nurse. I've been an ER nurse for a long time. I've also had informatic and our non-clinical jobs. I was an informatic nurse, and I worked in quality as well. I have a master's degree in patient safety and healthcare quality, and that's how serious I was about it. But my work has led me down this path, and now I do burnout recovery for exhausted healthcare workers. This is what the Trauma Informed Collective does. And I want to talk about trauma informed care, which is like so dear to my heart. And for a long time, I really thought I was doing trauma informed care because this is just what it sounds like what nurses do. And I'm really nice. I've been told for a lot of years, you're too nice to be an ER nurse. So I thought that this is what I was doing. And in 2024, I started training to be a SANE nurse. And that is where the trauma informed that's where my real training in it started. And that's where I realized very quickly, I have not been doing this. I go through the motions of it, but I don't think I've ever really I've ever done this before. So, but this SANE work, it has taught me that trauma-informed care is not just being the really nice nurse. It is a disciplined way of thinking about safety and power and control and choice. And that learning changed how I see my patients, how I see staff, how I interact with people. And it's just changed who I am on the inside. It literally changed me. I am not a nurse here at the hospital anymore. I do this now. So anyway, thank you all for inviting me to come do this. And also this talk, it's going to have 3 layers in it. We're going to talk about what trauma-informed care is, what it looks like in everyday nursing, and also why we have to apply that same lens, both macro and micro, like within us and also as a system. Like look at it. It has to exist in all three realms for it to work. Come on, baby. Okay. Just kidding. Just kidding. It's this. Yeah, there we go. That's fine. I got a finger that works. So why does this all matter? Trauma is everywhere, and burnout is high. Moral distress is high. Nurses are leaving the profession in droves. And we are asked so many times to give more than we are receiving. And a trauma-informed lens helps nurses shift from judgment to context. So instead of asking, why is this person being difficult? You're asking, what is this person protecting? And I like to say it it asks the question in the most curious way. Why are you like this? Like, it's not, why are you like this? It's, why are you like this? Why is this happening? Why are you like this? A trauma-informed lens is not only for patients and families. Secondary trauma exposure, workplace violence, grief, chronic overload, it affects us too. And this infographic, it talks about all of the factors of it. This is from the Surgeon General. These are all factors that they have identified as associated with burnout. And we are just being hit from every corner. I mean, like every angle, we are getting this. Yeah. So SAMHSA, or the Substance Abuse and Mental Health Service Administration under HHS, this is where I get all of my stuff. They're the ones that really are the authority in what trauma-informed care is. They describe trauma-informed care with the 4 R's. We need to realize that there is a widespread impact of trauma and that there are paths to recovery from it. We need to recognize the signs and the symptoms of trauma when we see them. We need to respond by integrating knowledge into practice. And we also need to resist re-traumatizing people. So plainly, it's just, we are meeting people where they are, and we are giving them a space to be heard and be empowered. And SAMHSA also frames trauma-informed care as an organizational approach. It is not just individual bedside skill. It cannot exist as only nurses doing bedside. That doesn't work. It is layers. And I just want you to know that good nurses cannot fully compensate for a broken system. No. Yeah, I tried to land that and then I messed it up. Okay, yeah. So the 6 principles of what makes up trauma-informed care. Here's a few examples of them and how they're used in everyday nursing. Safety is emotional and physical. It is explaining each step before it happens and asking permission to touch people, asking permission to come into a room, and protecting privacy, all those kind of things. It's really what AIDIT is. Trust is fewer surprises. Come back when you say you're going to come back. Oh, I'll be right back with that pillow. And then I know I've still got patients waiting on me to bring them back a pillow. Bless their hearts. And it's just, I'm sorry. But that's what it is like when you tell somebody, I'll be right back with this, you've got to follow through with it. It's tell them what you know when you know it. And if you don't know what we're waiting on and what the next step is, you can save so many problems by just keeping people informed. This is how You can prevent AMAs with this, you know. Peer support. This is about support between people with shared lived experiences. So this would be like connecting new parents with support groups. This would be like connecting newly diagnosed diabetics with diabetes educators, with diabetes, with other people in the community that support them. Like this is we cannot exist in a bubble. We all need support, and this is part of it. And collaboration. And this is about shared power and shared decision making. So this is doing something with someone, not to someone. Simple enough. Voice and choice. With the example of patient education, this is like, do you want to do this now? Are you awake enough to do this now? Do you want? Is there anybody that you want to include? Oh, my daughter gets off at 4 o'clock, you know, and I want her to be part of this. So yeah, let's accommodate them so that we can make sure that they get the most from our education, and instead of just saying patient declined, you know, let's do the things that's going to make it easier for them once they leave. Culture, history, and gender or identity. It means that we also need to stop assuming that our idea of comfort is universal. The way that someone experiences touch or eye contact or privacy, authority or modesty or family involvement, even the tone of voice, those are all shaped by their worldviews. And so what we would consider, you know, oh, honey, I've done this 100 times, you know, don't worry about it. That can come off as incredibly dismissive and not safe for people, you know. So we're meeting them where they are, and we're acknowledging that they are a whole person, not this diagnosis that is laying in the bed in front of us. And we take care of all of them. All of them. We're not here to treat their diabetes. We're not here to treat their heart problem. We're here to treat them. So instead of being like, this is what we need to do now, this is a better way to say that would be like, here's what needs to happen, and I'll walk you through it. This goes a lot with, we got to draw blood right now. I mean, the doctor said, well, it's still really scary. And also everybody here doesn't, I know you've drawn blood 100 times. You've probably done it 100 times today, but this is their first time and it really hurts. Or this is their 4th time today, and I don't understand why I have to keep doing it. I just gave you some blood. Why do we have to do it again? And so it's walking them through it, giving them information, giving them all of the information that they need so that they can be like, you know what, you're right. I do want the doctor to have all of this information. I want you to have it. So if you give them information, they will help. It just involves them. Relax. Holy moly. I still I've caught myself still saying that to people. And a better way to say that is like, I can see that this is really hard. Let's slow down. Let's take a break. This won't hurt. Don't no. But tell them what they're going to feel. Like, yeah, it's a shot. It's going to hurt, but it's going to hurt for a little bit, and it's also means to an end. It's going to help. This is what it's going to do. This is my bread and butter when it comes to forensic nursing, because every word that I say matters. Everything I say. And this is not fluff. This lowers defensiveness. This protects dignity, and this often gives them time this reduces escalation. So, and just think about it as if this was your mother, or if this was you, how would you want somebody to speak to you? So anyway, in my nursing, when I'm a sane nurse, I am just explaining everything that I'm doing before I am touching them. I go out of my way to kind of like, oh my God, you need to stop talking, because I just want them to know exactly what's about to happen. When I get to see people, I get to see them hours after something happened to them, something very traumatic happened to them, and I want to make sure that they feel like they are in a safe place and that they are here to heal. And I can't fix you today, but let me do all the things that I can to help. And I found this example as I was going through some stuff. But this was an example of a veteran that lived in a long-term care facility, and every night about 10:30, he would get really, really agitated, and it just sort of became a thing that people were just expecting, like, oh, it's 10:30, he's going to go crazy again, you know. But someone actually took the time to ask him about it, and then they realized it was because it was second shift going off and third shift coming on, and it was headlights that were coming into his window, and it was waking him up, and it was making him really irritated. And all it took was a blind, and then he wasn't agitated anymore. And this is an important trauma-informed lesson. Like, behavior often starts to make sense when we notice the trigger before we're labeling this person. And we are so quick to just call people non-compliant. We're quick to call them combative, or they're agitated, and all of those things. And it may actually just be their nervous system just trying to protect themselves. Man, I'm flying through this. I'm so sorry. I'm trying to speak a little bit slower. Now let's turn. Thank you. Now let's talk a little bit more. If trauma-informed care stops at the patient, then we have missed half the picture. Because this lens also, it has to include us. Because in healthcare, we are not untouched by what we witness. We are exposed again and again to workplace violence, to violence and just violence, moral distress, grief, codes, angry families, the secondary trauma of what just happened to this patient, you know? And then on top of that, we're expected to just keep moving and keep documenting and keep functioning and get this done. We don't have time for tears. And that's why I included this little image here, because it reminds us that clinicians are not just carrying an emotional load, we're also carrying an administrative load. When we ask people to stay calm and present and rational while they are under constant time pressure and documentation pressure, and this is also from the Surgeon General's office, like this is just part of their burnout thing. So as a SANE nurse, again, I learned this in a deeper way. Every patient that I see has just experienced the trauma, and I am caring for them in the middle of that reality. They're here. Their body is a crime scene. And that's what I'm here to collect evidence. But it's just so much more than that. When you think of a SANE nurse, that's what you think of, is I got the swabs. But it's just so much more than that. These secondary trauma, you cannot walk away from our work and be untouched. Secondary trauma, it is an occupational reality. It's just what we do. So when we turn this lens inward, we need to ask ourselves, like, what is happening in my body right now when you are having a patient that you're feeling really triggered? You don't necessarily, I'm not asking you to fix it right this minute, but listen to your body. Like, what just happened that is making my body feel very shaky right now? What did they just do? What did I just say? What did I just see? And what feels very threatened or rushed or out of my control? Everything. What do I need to do to be present? Because having, not just in nursing, but just in life, our heart and our head have to be connected. If we are nursing and we are bathing a patient. We're doing all of the things. We are doing that, but our mind is on the patient that is 3 doors down. We're not helping that patient 3 doors down, and we're not giving this person our full attention either. It's why we started this with this grounding exercise, to bring us into the here and the now. This is how we give good care, is being present. So let's talk about these 6 principles applied to self-care, one of my favorite subjects. Applying the 6 trauma-informed principles to self means treating your stress responses with the same respect that you would offer a patient. Don't discount yourself. And that means building safety within yourself. That means telling the truth to yourself. That means receiving, it's being okay with receiving support from your peers, from sharing the load, from making choices that protect your well-being, your sacred no, and honoring the ways that your identity and your experience affect how you move through the world. So, like, for instance, with safety, how about you stop checking your emails when you're not at work? I'm just saying, like, don't do that. Yeah, don't do it. Don't do it. Safety can also just mean just sitting down, closing the door where you are, or letting your body just come out of that threat mode with a grounding technique. Just to center yourself. That's safety. That creates safety inside of you. Trustworthiness can mean telling yourself the truth. I am overloaded. I am not fine. This pace, it is costing me. I can't do this. But it's also tracking or noticing those signs inside of you. It's also making a realistic promise to yourself and keeping it and following through with it. Like, I'm going to take my lunch break, or I'm going to leave work on time. I'm going to pack my lunch today, and then following through with it. Keep promises to yourself. You are worth keeping a promise. Do. Peer support. Checking in with trusted coworkers after a hard shift, being part of online communities, and with other people that have been there and they know what's going on. We have to. This is what nurses do. We're actually really good at this part. Voice and choice. Oh wait, collaboration. Advocating for yourself, girl. Advocate for yourself. I've had this load for 2 days now. This is my 3rd day. I can't take this group. Somebody else needs to take them. This is a really high acuity area. Can I swap one of these rooms? This even applies at home. You don't have to do everything at your house either. You can delegate responsibility there. That's not news. Yeah. And voice and choice. We have options for self-care routines. What feels right today? Like, have options for them. Like, if today is I love running and I'm going to go do my HIIT workout. I'm going to go do that. There's some days you got off your 3 shifts and you are jelly and you cannot do things, and you're not doing your workout that you planned on doing doesn't make you a failure. It does not at all. This is like, you are listening to what your body is doing. So you have like, oh, okay, well, today's my chill day. Today is the day I journal. Today's the day I crochet. Today is the day I listen to my true crime podcast all the way through. Like whatever but it's important to have layers of what you like things that activate you, that make you feel great, things that are down regulators, that bring you joy those ways. Because if you just laid in bed and I didn't go do my workout, and you just laid in bed and didn't do anything, then you just feel like crap because I didn't do it. But that's okay. Not every day has to be a workout day. Your body, you listen to your body. Your body knows. She knows what's up. So voice and choice matter because many nurses, we feel so stripped of our agency. And so even small choices like taking a break, asking for help, saying no, stepping away, I mean, those can all interrupt helplessness and help us restore our sense of control. And trauma-informed self-care in real life. This is where I want you to make a trauma-informed self-care very concrete. And I'm not asking you to overhaul your life by tomorrow or anything like that. This is just, I'm asking you to just take a grounded step. Maybe you first notice, you name what's happening to you without shame. Maybe you're regulating, like with just box breathing, just a big inhale and exhale to just slow down all of the big nerves that are happening. Maybe you just ground, maybe you go reset in the bedroom real quick. Maybe you choose one small doable action instead of trying to solve everything all at once. Maybe you connect by debriefing with a friend, maybe finally calling EAP, or maybe just saying the words out loud. Today was hard. Maybe you protect by drinking a glass of water, or a quart. You should probably drink. Going to the bathroom, eating something, or just setting that boundary before you walk into that room. They're going to talk my ear off, but I'm going to be in there for 10 minutes and then I'm going to leave. Those kind of things. In secondary trauma, it is part of what is being a nurse. This is what we were called to do. And our goal is not to feel nothing. We want to be able to recover from what we did. Because if we felt nothing, then we wouldn't be nurses. So now I want to widen the lens, sorry. So trauma-informed practice without trauma-informed workplaces, that creates a contradiction. And we can teach individual nurses to communicate clearly. We can teach them to, do this, say this and this and this first. You're always going to ask permission. You're going to do all of these things. You're going to offer choices. But if your system is punitive, if they are opaque with their policies or how things are done, if you feel rushed, if you're unsupported, that will only go so far. And organizations have to embody these principles. And that means safety includes physical and psychological safety. You have to be able to feel safe enough to speak up. You have to feel risk management. RCAs are not punitive, and that needs to be, y'all. My degree is patient safety, healthcare quality, and I wish so much that people really understood that an RCA has nothing to do with you, and it has everything to do with the process. Nothing. If it has to do with you, it goes to peer review or whatever. But that is not what RCAs are, but they just have this bad name and they keep being perpetuated. Same thing with RLs or MIDAS, if they're called that. Like they have a bunch of different names, but the reporting tool that hospitals use, it becomes so prevalent, or it has such a negative connotation that it actually becomes a verb. Like, I'm going to RL you. I'm going to. It used to be called SALT back when I was here. Well, I guess I'm still here, but when I was the first time I was here and upstairs. How many of y'all remember the SALT? Yeah, your SALT. Yeah, good times. Good times. SALT. It was a safety action learning tool. But I digress. That's not what I'm here for. Transparency. It means transparency and trustworthiness, where leadership explains new rules, but they not just explains them, but also how the decisions were made, who gave the input, and what staff can expect. Like, just lay it all out, just like you would with a patient. If you give people information, then they're more likely to comply. And yeah, okay, I'll go along with this, but we just need to understand what the why is behind it. In peer support, this is a real peer support team for staff after difficult cases and access to resources. And we work at a fantastic place that does a really good job with that. Code Lavender, things like that's what this is made for. All of those good things. It means voice and choice, where people have meaningful input where possible, where staff and patients have real opportunity for agency, participation, and shared decision making. This is shared governance. This is, I think, another thing that THR, actually a lot of hospitals do really, really well. And it also means culture, identity, history, and identity are taken seriously, including how bias, racism in medicine, and historical trauma, those all shape how our patients view care. Like those, having those things, I know DEI is the bad word right now, but these are, in order for us to be able to care for people the way that is the best way for them to learn, to understand, to feel like they belong and like they want to be part of this, then we have to acknowledge, there are things that we have to acknowledge. But just most importantly, like a nurse cannot be the only trauma-informed part of the system. We're all expected to be trauma-informed in systems. That's not always very trauma-informed. If I've learned anything working in hospital quality, it's that what gets framed as an individual nurse issue is often a system issue. Y'all, there are things that would come through as like, we're going to RCA this, and like, no. And, or we're going to do an RCA on this. And I'll come back and be like, well, this happened because of, if you really did a 6 Ys on this, you would see this is actually a system issue. This really didn't have anything to do with a patient, with the one particular nurse, the one particular doctor. This happened because of a systemic issue. This is, so it's recognizing those things and not being punitive on them. Where was I at? We individualize what are fundamentally organizational problems. If the workflow is rushed, if staffing is thin, if documentation burden is crushing, if people have little autonomy and inadequate support, then of course trauma-informed care is just going to be harder to sustain. So, but this slide is not all about cynicism or anything. I'm not trying to bring everybody down. I just want to be honest. Because when we tell the truth about this, we can advocate for something better, like better design, better staffing, better workflow, better leadership, better support. Like, we just have to say it out loud. And this is what trauma-informed care is. And also this little thing at the bottom, this is a quote from Texas A&M. All my SANE training is from Texas A&M University. And they said, yes, the future of nurse well-being will require moving beyond individual coping towards structured systemic support. This is how it's going to go. Ready or not, this is how it works. So this is where I want to leave us with something practical. So big changes matter, but repeatable small changes matter too. And sometimes the most meaningful shift is not like the giant initiative. It's just the one behavior that becomes, do it so often that now it becomes our culture. So if you're a nurse leader, if you're an educator, if you are someone with influence in your unit, which is actually every one of us, I would invite you to pick one behavior and one friction point to address this month. Maybe it looks like starting a huddle with a grounding pause when you're leading. Maybe it looks like standardizing permission-based languages or permission-based language for exams, procedures on like laminated cards at the nurses station that everybody has access to. so everyone's saying it the same way and saying it correctly. Maybe it looks like normalizing a debrief after hard cases, like being the one that recognizes we need to do that. Maybe it looks like protecting confidential pathways to counseling, mental health, or peer support, or just saying like, maybe EAP is a good thing for you. Just reaching out to somebody, sometimes just having somebody recognize that in you, that makes a huge difference. That people want to be seen, people want to be heard. And when you recognize that in somebody, you can make a big difference just by saying it. And maybe it just looks like auditing a workflow, because that's how my brain works, and just trying to make it better, doing a lean on it. So as we close, I want to leave you with 3 takeaways. First, trauma-informed care. It is a universal precaution for more humane, safe care. It's a good way to put it. Second, the lens does not stop at the patient. It belongs at the bedside, inside of us, and inside of the systems that we are part of. And third, self-care matters, and systems must carry their share of this work. And I will leave you with this final thought. At its core, trauma-informed care is about understanding before labeling, safety before control, and humanity before judgment. And I have a couple of handouts. There were supposed to be, I was supposed to print them out, I guess, but I didn't. But you can scan here, and I have a 1-page handout that was part of this. It is also, you also have all of my slides, and what else did I put on there? Oh, and all of my resources, all of my works cited, my references. That's going to be the next one, but that way you can actually click on each one of them and open up all of the infographics, all of the papers that I've cited, all of those things. And also maybe it's part of my business, the trauma informed care. That's who I am now, and you can keep up with me there too. So do I have? Oh, well, I don't want to do that. And just stay connected with me. Yeah. So this is what I do. Any questions? Yeah.
So a lot of what you discussed and what we're seeing in healthcare at bedside has to do almost with the culture of healthcare itself, and that we're seeing, all of my peers are just going in the room and they're doing the IV and I'm doing this, and we're not introducing ourselves and talking to the patient because we're all going through the motions. It's all there. So
yes.
what would you recommend? Personally, I just try to lead by example. What interventions and things can you do to try and shift that?
So this is to be part of nursing governance. Be part of somebody that be part of things where your voice can be heard, because people do listen to you. I've been on the other side of this, y'all, and I'm telling you, they do hear you. And growth or change doesn't happen because we said something. Change doesn't happen because we put in that RL today and it's still happening. But things do get, there are things in the works. It just takes a meeting and then another meeting and then talking to somebody in legal and then meeting again and then a policy and then we got to revise the policy. So it does happen. It just takes time. And again, this is where transparency from organizations, letting people know like, hey, this is how the process goes. That helps. So being part of making sure that your voice is going up, those kind of things, but also just leading by example, making those small shifts. And then you get the baby nurse that is following you around, and then they see that, and then that starts becoming part of their culture. That's part of what they do. It's little bitty increments that change things. And I'm an old lady nurse, and I changed. I got to, So it can be done. It can be. Huh. What else y'all got? Yeah. So I do. So little commercial for me is like, so I help with burnout recovery for exhausted healthcare workers. I do breath work. Tomorrow night I'm having a free class, and if you go here, you can sign up and be part of my free class tomorrow. I run retreats. I'm going to be, if y'all want to come and have a nervous system reset with me in Mexico in October, and do that with me. So, all right. Is there any other questions? I thank you all for your time. Yes, absolutely.